We looked at the cost of ophthalmic care in the United States, paid for by our Medicare system. More than 25% of the cost was generated by 2% of the people. Now, in this case, it isn't necessarily the end-of-life story that it is for overall medicine. It's the complications of treatment.
Right.
It is the endophthalmitis case that occurs after a cataract procedure. It's the retinal detachment that happens when someone's had a surgery that goes wrong. In the glaucoma world, it's late infection after a tube shunt or trabeculectomy. And the 1, 2, 3 procedures that occur to try to save that eye. The injection of antibiotics that are extraordinarily expensive runs a huge cost, so that we've met the enemy and it's us. In this case, if we were able to cut the number of complications by a factor of 3, we would cut our cost of glaucoma care and general eye care by 50%. So I think that we need to be working harder on the quality of care in specifics, on those things which are leading to devastating problems that wind up being quite costly. The average glaucoma patient in the United States only costs about $250 a year in actual cost to Medicare. So if we could make all glaucoma patients that uncostly by eliminating surgical complications, for example, many patients would be happier and we'd be saving a lot of money. From the point of view of public health, the biggest problems now are age-related macular degeneration, glaucoma, and cataract. And we've kind of got cataract beat. If you believe that being able to do surgery is a reasonable thing.
As long as there's no complications.
And if you don't have the complications. So for those of us like me who've had bilateral cataract surgery and it went fine, 3 days later you get a new eyeglass, and then a few months later you get a final eyeglass, and it's as if you were back to where you were when you were 48 years old. Cataract we're doing well, but if we could prevent it, we would save tons and tons and tons. Now there'd be an awful lot of unhappy ophthalmologists who make their living taking cataract out. But I don't think that would be a bad thing. With regard to glaucoma, we need to be much, much better at adherence. That's another little message in my talk. Patients simply don't take the medicine we have available, so we're working on sustained delivery drugs that we can place under the eyelid every 6 months. And that way nobody has to remember to take anything because it's there acting continuously for them. You'd only have to have half as good a drug to match what the eye drop is doing now, because patients are only taking half of their eye drops. So if a sustained delivery method was 50% as efficacious, it would be equal or 100% as good as present eye drops.
Yeah, exactly.
If it's as good as present eye drops under ideal conditions, it's twice as good.
Yeah.
So we'd probably do much less surgery because people wouldn't get to it because they were already pressure controlled. So it's another way of getting the cost down if we presume that whoever the company is that develops this new wonderful sustained delivery isn't going to charge $100,000 a month for it, And so our other problem is the pharmaceutical companies, your advertisers. I take it you're a commercial publication. And while the scientists who work at the pharmaceutical companies are all dedicated people, they actually have ended much of their own research work now. They're buying their product from somebody else. This is certainly true of the companies that I know in the United States. Many of them are multinational. So Pfizer, Merck, Burroughs Wellcome, even now Novartis, who formerly had a big research, in-house research direction. They fired all those people. And they have a very short-term view of what's going on. If they think they're going to buy the next drug from some startup, then somebody's got to be the startup. So we're starting up a startup.
In the hope that Novartis will buy the drug.
At the universities, and I think you're going to see a lot of that. I think you're going to see, our problem is we're losing the generic drugs because they consider those to be trash. They can't make any money on it. I'm just not even going to produce them anymore. Well, if the pharmaceutical houses don't produce them, our patients aren't going to have them. Right now, the thing we measure eye pressure with, fluorescent anesthetic combination drop you put in the eye and do applanation tonometry, it's becoming unavailable in the US. They've stopped making it. So I think what we need to do is to get the universities together with some people who like to make some money and have the universities begin corporate entities that make generic drugs and make them at a reasonable price and make a small profit. And there's no concern here about, oh my God, what's the venture here? If you want to produce a generic drug, you know exactly what it is, how to do it. All you have to do is make it and sell it with a 5% profit margin.
Yeah.
Well, that doesn't seem to be the business plan for the pharmaceutical companies these days.
No.
So I think we're going to have a new business model.
Right.
And it'll be
That makes sense.
angel corporations.
Sounds holy.
So there's a lot of things that are going on and that
Yeah.
could be going on, and we'll hope for that. For ophthalmologists, I think you're going to see increasing specialization because there's just too much to know and do
Yeah.
for there to be a general ophthalmologist anymore. And there's nothing wrong with that because I think it will improve quality if people are mostly focused on an area that they know extremely well and take care of. From the point of view of patients, that's going to mean that they'll have to be within a larger system than simply one physician's office.
Yeah.
Because every group is going to have the specialists needed for those and have a very efficient way of having patients dole their way through the system.